You can go live now.
Good evening, doctors. On behalf of Hetero Healthcare, I, Dr. Prashant Khandeparkar, welcome you to this webinar on troubleshooting PCOS. Doctors, as you know, at Hetero, we market products in multiple therapy areas like in gynecology, dermatology, orthopedics, pulmonology, etc. We have very strong R&D support, and we have developed many unique formulations keeping patient benefit in mind. Our endeavor is to develop products or formulations which will improve patient compliance and ultimate clinical outcome. We have developed, just to give examples, we have developed NSAID patches, rivastigmine patches for better patient compliance. Influenza division, gynecology, obstetrics, and IVF is an important therapy segment for us. We market products for vaginal health like Feminora, Peletra, etc. We have also formulated and introduced a vaginal film containing lactic acid. In oral formulation, besides Dydropal and other products, we market Mylotin, a unique nutraceutical product for PCOS management. Mylotin contains myoinositol and D-chiroinositol in the ratio of 40:1, chromium picolinate and melatonin, along with folic acid and vitamin D. To speak more about PCOS and management with nutraceuticals, we have Dr. Somashekhar Patil with us today. Welcome, Dr. Patil. Dr. Patil is MD DGO with MD Gold Medal from Dharwad, Karnataka. Sir is lecturer and consultant at Government Medical College and Wanless Hospital, Miraj. Sir has participated as a faculty in national and international conference. Dr. Somashekhar Patil runs a postgraduate institute in his hospital. Welcome, Dr. Patil. The entire session is yours. Thank you.
Thank you, Dr. Prashant. I'm now sharing my screen. Good evening, friends. Today, I'm happy to be in this webinar. At the outset, let me thank Hetero Pharma for organizing this meeting. The title of the meeting is Troubleshooting PCO, because PCO is the subject which all of you must have heard, rather bombarded with the knowledge of PCO for all the years, maybe decades together. So PCO is not a new, rather it is new in that it is becoming almost a pandemic and becoming very common in the adolescent girls. It's a very complex disease which is common in especially the reproductive age women. It starts in adolescence and lasts throughout the PCOS, and it may even extend into the menopausal age group. So it's very important to diagnose early and manage early to prevent many of its complications, which we will now be going through. If we see how to identify this PCOS, in many times it is not very difficult to identify a patient. By seeing itself, we can make out that this patient is likely to have a PCOS. For example, nearly 50 to 70% of the PCOS patients have hirsutism. That is the male pattern of the hair growth. And equally, nearly 30 to 75% of them are overweight. See, obesity and hirsutism are two very obvious signs in PCOS to identify. Even then, nearly 50% of the PCOS patients remain undiagnosed because they have no symptoms or nor they approach for the treatment. So with the same statistics, if we continue, every 1 in 5 women in India suffers from PCOS. So not only in India, it is now on the rise everywhere in the world. So almost it is becoming a pandemic. And in India, it is very common. And there are some sub-varieties wherein Caucasians and Indians do differ a little bit in the details of the disease. I need not have to tell about the PCOS, its history, and what it is. But I'll just go through a very short synapse on that. So one of the most prevalent endocrine systems. So this is a endocrine disorder. That is what is now established, though its exact etiology is not known. And it affects the women of reproductive age. And its new name, that is the present name, is hyperandrogenic anovulation, that is HA. There has been new academy or new group that is formed, which is called as Hyperandrogenic Society. So that deals with the PCOS and that gives the guidelines for the management and a continuing medical education on PCOS. This Steen-Leventhal syndrome is something which we heard during our post-graduation. It is there in the textbooks. When there was no sonography and modern facilities to diagnose were available, Steen-Leventhal diagnosed this condition and gave the first description quite early in this century, in the last century. This condition requires at least one ovary to be enlarged, that it should be more than 10 ml. Nowadays, modern sonography machines allow us to measure the volume of the ovary. So at least it should be more than 10 ml, and ovary should contain cysts which range from 2 millimeter to 9 millimeter, and the number should be at least 10 or more. So it is usually only diagnosed when the So in this stage, it is to be diagnosed only on sonography. In other cases, it usually is only diagnosed when the complications develop, that is significantly reduce the patient's quality. So when the patient starts or its patient feels that I am getting affected and something different is happening in me and I'm not looking very normal, then the patient's approach for the diagnosis and treatment. And as I told, Steen-Leventhal, as early as in 1935, had given the details of the disease. Its existence was found at that time, and they gave the clinical symptoms like hyperandrogenic symptoms, menstrual irregularity, and polycystic ovaries. But somehow, because it wasn't so common at that time, it remained dormant. Rather, nobody worried much, and everybody started concentrating on the symptoms like AUB and other hyperandrogenism, diabetes, hyperinsulinemia, and such things. And then original syndrome-like status was not attended in between. But of late, when these all things started becoming common, then we started naming it in a different way. And PCOS, it is nothing but the newer form of our old Steen-Leventhal disease. Now, symptoms which we have already been talking, different symptoms come at different age or requirement, as the patient requires different type of treatment depending on what is her requirement at that particular age. So the commonest thing, as we said, it is common in a reproductive age group. So the commonest symptoms is the irregular menstrual cycle, hirsutism, and infertility. And PCOS patients, if they conceive, they can also have pregnancy-related complications, especially the abortion. Then, as we have told that it is a metabolic disorder, so insulin resistance is the cornerstone of this disease. That can lead to diabetes in the later life of the patient if it lasts longer. And the patient also becomes prone to other metabolic disorders like dyslipidemia leading to cardiovascular complications. And more important and the less attended is the psychological symptoms that these patients develop. They are anxiety, depression, mood swings, reduced quality of life, and poor self-esteem. In the age where the adolescent girls would like themselves to be looking very good. During that time, they lose the shape because their weight increases, they become obese. And still worse is developing hirsutism. That is, the hair grows in the areas where it is not supposed to grow in the girls. So that adds to this psychological symptoms. And these girls, amongst their group, they become isolated and they feel separate from the group, and that adds again to the psychological symptoms like depression. Pathophysiology is it's a disease of theories. The exact pathophysiology of the disease is not known. After studying over so many decades and years, what we have found is in what conditions it is likely to be common and what are the manifestations of this disease. So the possible causes could be environmental toxins, pesticides. Nowadays, we find all diseases to be having a genetic origin, and this also is a genetic predisposition. Hence, it runs in families and siblings. Recent thinking is that some gut dysbiosis also is there, and that causes the hormonal changes and further pathophysiology. Hence, the use of prebiotics and the probiotics has come into use. And of course, the change in the present day diet and the lifestyle of women, because our earlier women of our grand ladies and all that, they used to do all the chores of the home, where these modern machineries were not there, when the modern facilities were not there. So everything they used to do manually. So it used to be a very heavy physical work, and probably that has now gone. And added to that, the sedentary habit of using mobile phones and sitting in front of the TVs for a long time, and during the same time, addition of the modern junk food in the form of pizzas and burgers. So all these, they produce a very fertile land for development of PCOS. If we see the manifestations, the changes in the hormones is that the LH is more than the FSH. Testosterone, that is the androgens, are increased, and thereby the sex hormone binding globulin is reduced. One more very important manifestation is the levels of the insulin are raised and the glucose tolerance is reduced. Though there is no obvious diabetes, but at a biochemical level, the body is trying to adjust with the insulin resistance. Hence, the insulin levels are high and the glucose tolerance is less. All these, they lead to the morphological picture, that is the polycystic ovaries. So if we see clinically, then it is, as I told, hirsutism and acne. Acne is very common in Indian girls. And it is an oligoanovulation, irregular menstrual cycle, subfertility, and of course, metabolic disorders lead to the dyslipidemia, and patient becomes prone to even hypertension and the cardiovascular disorders. The theoretical background is that high consumption carbohydrate, hyperinsulinemia, hyperandrogenemia, and persistent low-grade inflammation. So as the disease origin is not properly known, all its manifestations are being studied, and one by one, they come to fore. For example, very recent finding is the persistent low-grade inflammation. So even a long-term anti-inflammatory drugs have been tried in treating the PCOS. Now, always as it happens, there are various associations which formulate the diagnostic criteria for the PCOS. So we have all been going through these criteria in all the conferences and all the webinars. So I'll not go much into the details. The National Institute for Health and Rotterdam is the very old criteria, and now again in 2003 they have been diagnosed. And presently, as we call an androgen access society, or the Hyperandrogenic Society, which is given the criteria which are now followed. So mainly, the signs of hyperandrogenism are common for all criteria. And of course, the clinical and or the biochemical signs of hyperandrogenism, that is acne, hirsutism, nigrika, and all these things which are clinical, and biochemical, that is increased testosterone, decreased sex hormone binding globulin, and increased LH level. And second most important is the oligoannulation. And third one is the morphological or the sonological finding of polycystic ovaries. So in all these cases where we want to diagnose before, we have to exclude the other endocrinological disorders which can lead to the same symptoms, for example, Cushing syndrome and such things. So once we rule out these other conditions, then the signs and symptoms or the clinical and the biochemical signs of the hyperandrogenism is a baseline. And in addition to that, either polycystic ovaries or oligoovulation, that forms the criteria for the diagnosis. Now, as we have been discussing, as I told you many times, we may repeat the same things. So again, we are telling about the clinical hyperandrogenism. That includes hirsutism. And one more important finding that we'll be discussing is the alopecia or the loss of hair. And this is a very typical male type of loss of hair occurring in the female. So hirsutism is again here, it is develops on the face and on the bodies where usually the girls or the women do not have the hairs. So it is a most common and very obvious clinical indicator of the hyperandrogenism. Acne, as I told you, is very common, very prevalent, and Indian women are, that's the Mediterranean in descent, they are very much prone, so there the incidence is still high. Alopecia, as I told, is the loss of hair, that is especially as the baldness occurs in males, especially the crown area, hair is lost. The same hair loss, a reduction in the hair can occur in the same areas. Less than 5% of women with PCOS complain of hair loss. So though it is there, many patients may not complain. The normal, now coming to the ovulation and the menstrual disorders, which ultimately leads to infertility. And then we all know the normal gap that we should call it as normal menses. But here, mainly it becomes an irregular menses, mostly the delayed menses and a decreased bleeding, that is oligomenorrhea. These are the common symptoms. Some patients can also present with polymenorrhea. Polycystic ovaries are mainly the morphological findings. The name of this disease comes from the morphological finding of the ovaries on a sonography. They are very commonly observed in the hyperandrogenic patients. And ovaries are typically very much enlarged. And the criteria put forward, they differ, but at least 10 to 12 follicles have to be seen. And the stromal size that is more than the follicular size all put together. And the size of the follicles has to be between 2 and 9 millimeter, the number being more than 10 or 12 sutures, 12 cysts. Now, this is a little interesting. The prevalences of the polycystic morphological look is very high. But the moment the ovaries look polycystic, they may not be having the polycystic syndrome or disease. However, 25% of all women and even the women in the sounds, women using oral contraceptives also meet the ultrasonic criteria for polycystic ovaries. So we do sonography so commonly and we see ovaries being polycystic in many of the patients. So even normal women, 25% of them can have a polycystic look. Even if they are on contraceptives, they can have the polycystic ovarian morphology. Still, moreover, polycystic ovaries are commonly observed during the normal pubertal development. So that is the age when the patients develop PCOS also. But just by mere presence of polycystic ovaries, we should not immediately jump into the conclusion of PCOS. The 2003 Rotterdam diagnostic criteria expanded the population of the women that might be assigned as diagnosed of the PCOS by approximately 50%. So this changed the incidence and the statistics. So we have to be very much discriminate when we want to diagnose the PCOS. The polycystic ovarian morphology is not the only one, and it is not the sole one. As I told you, abnormal gonadotropin secretion, again, will be just touching this subject. So increased secretion of LH concentrations. Now, many say the LH and FHH ratio is reversed, that is 2:1. So all these again depend on what laboratory we are using and what type of assays we are doing. So what is more common is the presence of the luteinizing hormone more than the follicular stimulating hormone. That should suggest us the PCOS. Now, a little more about the insulin resistance, as this is the very cornerstone and the very basic pathology that is seen. The overall prevalence of the insulin resistance is up to 75%, and it is still greater in the obese than in the lean. So PCOS is seen in lean women also, but the lean women do not have more of insulin resistance. Most women with PCOS and insulin resistance are young and have ample pancreatic B cell reserve. Consequently, they are able to generate compensatory hyperinsulinemia. To compensate for the resistance, the body produces more insulin. Hence, their insulin levels are very high, especially the fasting insulin levels. If we do, they are more. Dyslipidemia, I will not go into these details. No doubt, we do investigate the lipid profile, especially the fasting lipid profile. Not so very commonly, but it is advisable that we do these tests. And then, of course, we are taking the help of the physicians, hence what lipid is more, what lipid is less. So we may not go into more details of this. Now, as I told you about the investigations, how to evaluate the suspected polycystic ovarian syndrome. I'll just read out all the investigations, but we may not do all this investigation in all conditions. We may have to be a little discriminate. Thyroid is to be done in all. Prolactin is to be done in all. Oral glucose test can be done in little aged or wherever there is a family history or when they are obese. Fasting lipid profile, yes, I just now told, depending on the situation. Endometrial sampling in those patients who are prone and who have menorrhagia as main symptoms. And serum testosterones in women with moderate or severe hirsutism to differentiate other causes. And other investigations are not routinely done, like serum hydroxyprogesterone, etc. And also, in some cases, we may have to do an overnight dexamethasone suppression test. So infertility is a very common and disturbing symptoms, and many patients who come for infertility, then we come to know that they have got PCOS. So nearly 40% of all infertile women have PCOS, and its anovulation is the cause of the infertility. And in addition, the importance is that these patients, when they conceive without treatment, they can have more incidence of abortion, that is up to 40–50%. So as soon as they conceive, we need to take care of their abortion incidences. Plus, we need to continue the treatment of the same drugs as we use in PCOS in especially the first trimester of the pregnancy. The investigation which I already told, here I'm just listing it. I'll just skip this slide because I've already discussed. If we now come to the goals of the treatment, so one of the most common symptom being the irregular cycles. So these patients, they require or they insist on regularization of the cycle. So we have to regularize their cycle and we have to improve their insulin sensitivity to prevent them from going into full-fledged diabetic. We have to reduce their dyslipidemia and to improve their looks. And of course, we have to treat their fertility and we have to decrease androgens to treat, especially to reduce the occurrence of the hirsutism and acne. So, principles of management. PCOS is a condition that spans the lives of women. Fetal programming, this is the new, again, a theory that the women who are having PCOS, their fetuses are programmed in the intrauterine life, and later on in their life, they develop the PCOS in adolescence and even up to the old age. Menstrual and fertility problems evolve into metabolic complications later in life, and they lead to further problems like hypertension, cardiovascular disease, and even the carcinomas in the menopausal age group. Precise diagnosis is important, especially in the extreme ends of the age, wherein other conditions, they crop in, confusing our diagnosis. Then lifestyle therapy tends to be the first step in PCOS management. As we told you, we don't know the cause. So lifestyle management forms a very and most important form of the treatment. And then comes the pharmacotherapy. Pharmacotherapy has many drugs, as we do not know the exact cause. So depending on the symptoms and depending on the age, depending on the requirement of the patients, the pharmacological agents, they differ. So lifestyle improving nowadays, it is becoming very common, and we know that many of the girls are now becoming more conscious about this. And this two very important things I will tell is, one is the exercise. We have to increase our physical activity and very regular and of course little more vigorous than the easy regular exercises have to be done, and it has to be consistent. And along with that, very important is the diet. If there is no specific diet, at least we can, in some resistant cases, we can take help from the nutrition specialists, or simple is to avoid the oily and the fatty things, reduce the carbohydrate and increase the protein intake. So there are many drugs to reduce the weight, but unless there is added with the exercise and diet, the weight reduction cannot happen. And of course, this behavioral change is very important, that one has to make up the mind first that I am supposed to do myself, then depending on the doctors, to improve my PCOS. So this is very important mindset that these women should develop. So they should go for slower eating and some such things wherein psychologically very strong decision has to be made. Now, varieties of the pharmacotherapy is there. That is the oral contraceptives who reduce the androgen levels that contain the drospirenone, and of course the progesterone has to be there, or we can give only progesterone pills to treat the PCOS. Then the most common things which are used are the inositol, that is myo-inositol and the D-chiroinositol, or the combination of two, or independently also they are used in some studies. And metformin is one of the very old drugs which has been used, especially because it is all the insulin resistance that is the cause. And lipid lowering agents also can be used in patients who are having a very abnormal lipid disorders. Now, as we see, there are many symptoms of this disease, and at different ages, different symptoms becomes prominent, and the treatment also has to differ accordingly. So if it is a lean PCOS, then we just correct her PCOS. If it is infertility, we may have to do an ovulation induction. If it is obese patient, we may have to concentrate on the weight reduction along with the PCOS treatment. And insulin resistance is very common. So to prevent her from going for diabetes, we have to concentrate on the drugs which reduce the insulin. And also in the background, there is a lot of hormonal imbalance we need to correct. So if we see different conditions and different modalities and different pharmacological agents. So in presently available drugs, none of the formulations give us a complete therapy which can be used common in all patients. Coming to some of the very important formulations that are used in the drugs. That is, one is the very most common thing are the inositols, that is the myoinositol and the D-chiroinositol in the range, in the ratio of the 40:1. That is supposed to be a physiological. Some of the investigators agree with and some don't agree. But this combination is supposed to help regularize menses and improve egg quality, and it restores ovulation. And chromium picolinate, it adds to the above drugs, and especially it is useful in improving the insulin sensitivity. Melatonin is supposed to improve the metabolism of the ovulation, and also it is a sleep-inducing drug. So it helps in the patients who have got more of a psychological symptoms, especially the anxiety. So melatonin can help in reducing anxiety. And vitamin D and folic acid are the commonest drugs, and they have got role in the ovulation induction and improving the quality of the oocyte. So if we combine these four drugs, that nearly comes to the ideal situation. Now, the many decades we have been hearing to myoinositol and the D-chiroinositol combination. So the combined administration of the MI and DCI in physiological plasma ratio of 40:1 is considered as the first line of approach, as it is supposed to help in many of these conditions. So the recommended myoinositol dose is 2000 milligrams twice a day. There have been situations where only myoinositol has been used in higher doses, and even D-chiroinositol also has been used in higher doses as a single drug. But the most common formulation contain the 40:1 ratio of the myoinositol and the D-chiroinositol. This ratio is a little confusing because the myoinositol is in a different levels when we measure in plasma, and it is in a different concentrations when we measure in the ovarian tissue. And it has got a very different role in the plasma, and it has got a very different role when it is in the intra-ovarian situation. And both these drugs are the contents of our food, so dosage doesn't matter. So we have to use them in adequate quantities. That is more important. MI-DCI ratio were able to improve the regularity of the menstrual cycle, acne score, and also correct the endocrine and metabolic parameters. So the combination of these two in this particular ratio has helped in many of the symptoms alleviation in the PCOS. Now, the newer addition or the important addition is the chromium picolinate. It is supposed to combination is supposed to increase its increase absorption from the gut. When given in PCOS, it reduces the hyperinsulinemia. It acts by enhancing insulin signaling. It improves the insulin sensitivity and facilitates fat loss. And it is better tolerated than the metformin. As we see, metformin is another very commonly used drug. Because it is not well tolerated, it has got some symptoms. The chromium picolinate is being used in place of metformin. The combined action of both inositol and chromium picolinate, they help each other, and insulin regulation will help to treat the underlying cause of the PCOS. Now, there have been many studies. If I go through in detail, we may cross the timing. So this study is especially, as we see on the screen, it is the importance of the chromium picolinate. It is comparable in its action to the metformin, but it doesn't have the side effects of the metformin. Metformin is supposed to have some side effects. So chromium picolinate, it is used to ameliorate all the side effects. And at the same time, it has equal or even little better efficiency compared to the myoinositol. This slide or this study also indicates the same. And the newer addition is the melatonin. As I told, melatonin has got multiple actions here. It supports the nuclear maturation of the oocyte. So the oocyte quality is supposed to improve. Its fertilization capacity is supposed to improve. So the melatonin may improve the oocyte quality and increase the pregnancy rate. And it's also a sleep-inducing hormone. Rather, I would say it reduces the cortisol level and it can reduce the stress levels. So these PCOS patients are already, as I told you, having a lot of stress. So melatonin is going to help them. So the same thing has been proved by these 2-3 studies, which I'm skipping. And folic acid and vitamin D are the very important parts of our body. And they are supposed to help in many of the PCOS cases wherein they are supposed to improve again the oocyte quality and help in management of the PCOS. Now, this is all the repetition which I told you just now. This webinar doesn't end unless we give some studies, or I would say the self-experience. So I will share in some of my own experiences. When I use the combination of these 4 drugs, which I told, especially the MIDCI combination, melatonin, folic acid, and vitamin D3, in a patient which was adolescent and obese and having hirsutism, came for the irregular menstrual cycles. So I put her on this combination for nearly 4 to 6 months. So her menstrual cycle regularity was established in 2 months. And at the end of few months, or 4 to 6 months, there was considerable improvement, reduction in her hirsutism, and even she could control some weight. And along with the exercise and diet, it was beneficial for that patient. So this was one experience. Second, in infertility patients, especially those patients, one patient was 32-year-old, having oligomenorrhea. She was obese. So her studies indicated that she had PCOS and her quality of the ovum was poor. She was not able to conceive even with some cycles of IUI. And this patient, when she was put on the combination which I just told, I put it for more time. I put it for nearly 4 to 6 months, and it improved her ovulation and quality of the ovary, and her cycles became regular, and at the end of 5 months, she conceived. I continued this combination in her first trimester to prevent the abortion, and she continued her pregnancy near term. And in one more patient who, of course, had her children, but she came mainly for obesity and irregular menses, and especially the oligomenorrhea. And when we investigated her sugar, so she was a borderline case of the insulin resistance, which was leading to the early diabetes, and she had a family history. And in this patient also, along with other drugs, I used this combination nearly for 4 to 6 months, and she could improve with her weight. Her bleeding during menses improved, and her sugar levels, they came to a normal or to a normal level in such a way that she did not require the treatment of the diabetes. So these are some of my own experiences. And with this, I put an end to my talk, and I would hand over the mic to Dr. Prashant for the further deliberations, or if there are any questions. I think we are left with
Yes.
another 5-10 minutes.
Yes, yes.
So let us go only for 5 minutes. We'll finish in.
So thank you so much
the-
for this lovely session.
If there are any- Yes.
The case studies were wonderful. Sir, amongst the symptoms of PCOS, which group of symptoms are more common? The reproductive system symptoms, the metabolic symptoms, or the psychological? Which are more common?
So presently, I would say in my experience, the young girls coming with the irregular menses
Okay.
and hirsutism. So as we have been all the time studying the irregular menses, oligoovulation, and hirsutism
Yeah,
are
yeah.
the common symptoms which are very obvious. And of course, very next, as you told, the infertility, when these same girls get married, then the infertility becomes more important.
So metabolic symptoms will be more common in the little older patients, as well as reproductive will be more common in the younger age
We
group.
don't treat them in time.
Yeah.
If it lasts longer, if this annulation sorry, if they continue, then they develop the
Metabolic.
disorders.
Sir, suppose now at times metformin may be required along with this type of product, although it has chromium picolinate in it. But does it happen that the duration of prescription of metformin comes down if this combination is co-prescribed?
You mean over a period of time, the dose of metformin, you mean?
No. Sometimes in some of the patients, although we prescribe this type of combinations of metabolic symptoms, they may require metformin. But what I'm trying to ask is, if this combination is prescribed to those patients, will metformin duration of treatment come down, or shall we prescribe metformin for a shorter duration of time?
Yes, you are right. Because the metformin treatment is supposed to continue for more than 6 months.
Correct.
Benefits. But if we do the adjuvants, the results are earlier, so that we can reduce or stop the metformin to reduce its side effects.
It's a lovely drug, but the side effects of metformin are sometimes a little troublesome.
Yes.
Generally, you prescribe this product for about 3-4 months at least.
Yes, minimum 3 months.
Minimum 3 months.
That duration is very.
And what is patient response, sir? The tolerability?
This particular combination is well tolerated.
Well tolerated. That's great.
So hardly there are any complaints.
Because unless they tolerate it, they would not take it for a longer period of time. That's another.
Yes.
A lot is spoken about this ratio of myo-inositol and chiro-inositol. Do you really think it's 40:1 is helps the best? Your experience, sir. It's your experience.
Other factors which will confuse. One is they are our routine food content.
Absolutely.
So them, even if we are not taking their drugs, in our food itself, these inositols are there.
Yes.
And, their action differs at a different level of concentrations. And their action differs when it is extracellular and when it is intracellular.
Absolutely.
The tissues of the ovaries, the myo-inositol acts in a different way. So that way, if we see, is very difficult. Somewhere in the investigation during one study or during one part, it was found to be 40:1.
40:1, correct.
Found that it is 40:1.
To one physiological
that has become almost a customary.
Correct.
That it is 40:1, but it is not mandatory
or
absolute.
How soon you see patient response once you prescribe? That will also depend on patient condition, but minimum 6 weeks time it starts. I think for the time being, that is all, sir. If there's something, we'll definitely come back to you. But thank you very much, sir, for this lovely session.
Again, I thank.
Some of the facts were wonderful. I mean, your case studies are very interesting.
All the speakers and all the participants.
Yes, thank you for all the participants. Thanks, everybody.
Very much. Yeah. Thank you.
Thank you. Over to you, Priya.
When should I leave the meeting?
Thank you, doctor, so much for giving your, removing your precious time and being a speaker with us. I thank all the delegates who have attended this webinar. Again, I understand that evening is a very, very crucial time, but still you have removed your time and attended the webinar. So thanks a lot for all the doctors who have attended this webinar. Dr. Patil, I must say that your presentation was really very much insightful. It was very well presented, and your case studies were extremely good, and they were very well spoken and very informative. So I really enjoyed this presentation. Thank you so much, and I'm looking for your continuous support and cooperation in future as well. So thanks a lot, Dr. Patil, and thanks that you were with us, and we're looking for long-term association with you as well. I thank Dr. Khandeparkar as well for coordinating and being a complete, advisor for this webinar, and for all your help that you have given us in the beginning, during the webinar, post the webinar. Thank you so much, Dr. Khandeparkar. You are a wonderful person. I also thank my senior Jyoti madam, who is my superior. She has been very, very cooperative and very much supportive and guiding a lot.
Yeah.
Yes, I also thank Joyjeet sir and our head, national sales head, as well as Patwardhan sir for being, helping us out. I also thank the entire hetero sales team who are present currently with us, the managers, TSCs as well, because without them, this webinar wouldn't have been possible. They really worked very hard for inviting the doctors, sending me whatever I asked. They were very prompt in delivery with all the follow-ups and everything. So I thank the entire hetero team for working very hard and making this webinar a huge success. I also thank the IT department, Mr. Vijay and his colleague Sandhya, who have joined us, because they have really ensured that this is smooth sailing, and they were always present before time and provided all the technical help, So I thank the entire IT team as well. Thank you, Sandhya, and thank you, Vijay. Okay.
Thank you, Vijay.
So with this, we will close the webinar, and thank you, Doctor, once again, Dr. Patil, for being with us. It was a wonderful presentation, and we got a lot of insights from you, and your case studies were really good and very interesting. And looking forward for your continuous support in future as well. Thank you so much. And with this,